Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with a specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
So let me just summarize a little bit about adverse events here that you may notice in patients being treated with HCC. This is a table, again, pretty busy with the data from 3 very large phase 3 trials for VEGF-targeted therapies. And the first 2 columns are regorafenib and cabozantinib. These are multi-tyrosine kinase inhibitors, again, improved in second-line HCC. Regorafenib is very similar to sorafenib, which continues to be used sometimes in first-line HCC. You can see that the side effects of regorafenib and cabozantinib are relatively similar. Again, these are slightly different groups of patients, so I wouldn't compare them directly, but I think that the major takeaways are that multi-tyrosine kinase inhibitors like regorafenib and cabozantinib cause hand-foot syndrome, cause diarrhea, cause fatigue, cause hypertension. That's something that's seen with all VEGF agents. And so those are the big side effects to take away from this. Hand-foot syndrome, I would say, is the single most common and most annoying side effect of most of these multi-tyrosine kinase inhibitors. Hand-foot syndrome, in case you haven't seen it, is where the skin on the hands and feet gets red and can even blister. In general, when it's not that severe, we treat with various skin lotions, most commonly urea cream. When it's more severe, we can pause the drug, go down on the dose of the drug. Many patients require dose reductions. Sometimes high-potency steroids can also be helpful. On the right column, we have the data for ramucirumab. As you may recall, ramucirumab is a VEGF-targeted antibody, so not a multi-tyrosine kinase inhibitor. As a result, it does not cause the hand-foot syndrome that we see with regorafenib and cabozantinib. It does cause other VEGF-related side effects, such as the hypertension. And so, again, the side effects are somewhat different for ramucirumab, and it can be a good option for patients who don't tolerate multi-tyrosine kinase inhibitors, for example. We're moving to the first-line HCC. So again, the options in first line, just a reminder, are bevacizumab for eligible patients. For patients who aren't eligible for bevacizumab, our options would be sorafenib or lenvatinib. Sorafenib, lenvatinib are both multi-tyrosine kinase inhibitors, so they have many of the same side effects. I think the main takeaways are that sorafenib causes more hand-foot syndrome, whereas lenvatinib causes more hypertension. So you may consider this as a reason to choose one or the other, since these are somewhat differentiated in terms of their side effects. The most common option in the first-line setting for eligible patients would be bevacizumab. Atezolizumab, as you know, is an immune checkpoint inhibitor. And so even though it's very well tolerated, one of the side effects we always worry about is the emergence of immune-related adverse events. What does this mean? Well, we're turning on the immune system to hopefully fight cancer, but the immune system can get confused and can attack self instead of the cancer. And what can happen is essentially any organ in the whole body can be attacked. And I've seen everything on this page at some point for patients receiving immune checkpoint inhibitors. I would say the most common things we tend to see are thyroid dysfunction, so hypothyroidism if the body attacks the thyroid glands, hepatitis. Again, there may be some increased signal there for HCC patients because their livers are already borderline, but everything on this page has been described with immune checkpoint inhibitors. And so you really need to be vigilant when you use these drugs and really pay a lot of attention to patient side effects, because anything they report could be a tip-off for an immune-related adverse event. And these adverse events can be very tricky to diagnose. So I personally find this to be a really important figure here. And this is something that I'd like everyone to hold on to. whenever they treat a patient with a checkpoint inhibitor, HCC or not. And that is that there really is a typical time course for immune-related adverse events with checkpoint inhibitors. So patients, when you talk to them about side effects, they often think that they're going to get the infusion, go home and have a side effect that day. But really, it takes a while for the immune system to get revved up to the point that patients experience immune-related adverse events. The most common window for immune-related adverse events are in that sort of 4 to 12-week range, I would say, a little bit earlier when you give two checkpoints together, such as ipilimumab and nivolumab. I would say in general, the rash is sort of the first side effect we see. It's an early immune-related adverse event, whereas things like hepatitis tend to happen a little bit later in the treatment course. The interesting thing is after patients pass this sort of 14-week window, the rate of immune-related adverse events goes down dramatically. It doesn't mean that it goes to zero, but it goes away, with the exception of endocrinopathies. So I have had patients who have been doing great on atezolizumab and bevacizumab for a year with their tumor really well controlled. And then they tell me, Doc, I feel so tired, I can't get out of my chair. And we work them up, and lo and behold, they've developed adrenal insufficiency at a year after starting because they attacked their adrenal glands. I've seen a patient develop type 1 diabetes 2 years after starting a checkpoint inhibitor. And so these sort of bizarre endocrine issues can crop up anytime. So you have to be extra vigilant with these patients. I'm sure that there are many patients who become fatigued, and patients think that, it's their cancer acting up when really all they've done is developed adrenal insufficiency. So please be vigilant with these patients. How do we deal with immune-related adverse events? I would say in general, when patients have very mild symptoms, often we can just continue therapy without interruption with just supportive care. So very mild diarrhea, we can give antidiarrheals. Patients with mild rashes, we might give sort of topical steroids to the rash and just continue therapy. When patients have more severe side effects, such as grade 2 side effects, that's where usually we'll hold the checkpoint inhibitor therapy. Now, remember, these therapies stick around for weeks. So holding the therapy is not really a treatment. Often these patients also need corticosteroids to bring the immune system back down. But hopefully, if it's a grade 2 sort of side effect, once the toxicity resolves to less than or equal to grade 1, and once the steroids have been tapered down to about 10 milligrams of prednisone equivalent or less, it's often possible to resume therapy. When patients have more severe side effects, such as grade 3, this is where steroids are clearly indicated. Often these patients need to come into the hospital. Checkpoint inhibitors should be stopped. And in most cases, we permanently discontinue the checkpoint inhibitors for these more severe toxicities. I would say in general, again, every single case is unique and needs to be managed ideally with a disease expert. So for example, for patients with hepatitis, I like to confer with my hepatology colleagues, but in general, these patients need a 6-week steroid taper or more. So going down by about 10 milligrams of prednisone per week, starting at about 1 milligram per kilogram of prednisone equivalent. So those are general guidelines for management. So again, key things to take away from this discussion are that immune-related adverse events can truly happen anytime, but generally they happen in that 4 to 14-week range after starting a checkpoint inhibitor. And in terms of the tyrosine kinase inhibitors, they have, again, a lot of overlapping toxicity of diarrhea, hand-foot syndrome, proteinuria, high blood pressure. Some of them have a slightly higher rate than others. And I think that ultimately, it's really important to become familiar with these side effects and to counsel patients, and especially with checkpoint inhibitors, to really tell patients to report everything, because early diagnosis of these checkpoint toxicities can be life-saving. So with that, I'm going to turn it back over to Bridget for some boot camp takeaways.
Thank you. So after all you've learned today, these are the things we want to make sure you leave us with. Always want to offer surgical resection, liver transplant, local ablation when possible for patients with early stage HCC. Atezolizumab and bevacizumab is the preferred first-line therapy for most patients with advanced HCC in the absence of complications. Optimal sequencing of therapy is important, and treatment choice should be based on the patient and disease-specific characteristics. And we, of course, want to educate patients receiving systemic therapy to recognize these specific AEs we've discussed and notify the providers of any changes during the time of their therapy. With that, we're going to move on to our case study. And our first case study, I'm going to turn over to Dr. Singal.
Yeah, thanks, Bridget. So, John, this 54-year-old male who initially presented for hepatitis C treatment, he was found to have, this single lesion on screening. He underwent a resection, and then unfortunately, 4 years later, returned symptomatically and then had this large liver mass. And that large liver mass was actually HCC with portal vein invasion and an adrenal metastasis. In this case, I think all of us would agree that atezolizumab and bevacizumab would be the preferred option, given the fact that he now presented with advanced stage HCC after this resection. And in part, this is because he didn't have evidence of portal hypertension. Once again, with an upper endoscopy showing no varices, he has a platelet count of over 100,000. So all of these things portend that he will tolerate atezolizumab and bevacizumab well. What if John instead had a history of recent variceal bleeding, actually had significant portal hypertension, recent variceal bleed? What would you consider in the first line now? Would you still consider atezo and bev, or would you have to move on to something else?
Yeah, this is a question that comes up all the time in my clinic. Again, bev-atezo is the preferred option, so you need a reason not to give bev-atezo to a patient with advanced HCC. But recent variceal bleeding is a reason to consider something else. I think, this is a time where I would ask, what was the variceal bleeding? Was it banded? Is he likely to bleed again or not? It's a judgment call. So I don't know. How do you feel about this as a hepatologist?
Yeah, so Mark, the devil's always in the details, as you say, and it's always hard to sort of present a complicated patient in a single slide. And so, yeah, I think you bring up good points in terms of, what was the variceal bleed like? How was it treated? How recent is recent? All these things I think are important to consider. But when we take a look at, the IMBRAVE 150 study, as you went through, and you take a look at the inclusion-exclusion criteria and the safety profile, which has been demonstrated for atezo-bev, this really has been demonstrated in a patient population that did not have a history of variceal bleeding recently, underwent an upper endoscopy, did not have quote-unquote large varices or untreated high-risk stigmata of bleeding. And so this patient would not have qualified for the IMBRAVE 150 study. And I think that, as you know, Katie Kelly and colleagues wrote a sort of nice editorial for the IMBRAVE 150 study and really stressed that we have to be careful. Even though this is such an exciting therapy, we can't go off the rails and treat everyone and anyone sort of with this combination. And so, at least in our practice, based on sort of the information we have from this simplified presentation, I think this is somebody that we would say, like you said, there's unfortunately a reason he's not eligible for atezo-bev right now. And we would consider alternative first-line therapies. And, as you pointed out, the alternative first-line therapies that we would have for somebody not eligible for atezo-bev at this time are sorafenib and lenvatinib. You talked about the press releases, so we'll have to see what Himalaya looks like. But theoretically, if, depending on sort of the full data, maybe durva-tremi, better survival than sorafenib. And so maybe durva-tremi in this patient. We'd have to see what the data look like. Once again, devil's in the details. But I think right now, if he came in today, sorafenib and len would probably be what we treat with.
Yeah, no, I agree completely. One of the challenges is that even though the risk of bleeding is lower with sorafenib and lenvatinib, those agents also have a risk of bleeding. So, again, I think there's no perfect solution right now. The NCCN does allow single agent nivolumab as an option. Again, it's not something that we reach for often, but for patients at extremely high risk of bleeding where no VEGF therapy can be given, that is another thing to sometimes consider. Again, I think, in the near future, assuming the data matches the press release, this would be an ideal patient for durva-tremi.
It's such an interesting point that TKIs include VEGF inhibition, right? And so it's kind of funny that we're like, oh, he has a contraindication to, beva, but then we're using a TKI, which includes that same mechanism of action. And it's simply because of the way the clinical trials were structured. So it's a funny thing. Yeah. I guess it's what we have right now.
Agree completely.
So
I guess the advantage of the TKIs is the half-life is shorter. So
yes.
They're not going to bleed continuously for 3 weeks.
Exactly. Very true. So, Mark, the second sort of iteration of this is sort of, John, I guess 3.0 here is I would love it if every patient who came in was a Child-Pugh A. It would make, I think, both of our lives so much easier. But, I think all of us recognize that unfortunately, when you're treating HCC, a huge portion of our practice are these patients who are not Child-Pugh A. What about these patients who are Child-Pugh B? Once again, let's say John underwent his surgical resection 4 years later, despite unfortunately getting his hepatitis C treated. Let's say he also had fatty liver. He was an obese male, had diabetes, had continued progression of his liver disease at that time. And so when he presented with his advanced stage HCC, what would you do if he was a Child-Pugh B patient?
Yeah, this is another question that comes up all the time. The thing that I would say, and you know this better than anybody, is that the Child-Pugh score was never designed to assess patients with cancer, right? It's really an assessment of underlying liver function. And so patients with cancer often have high bilirubins and have low albumins just related to their cancer. And it doesn't necessarily mean that they're truly Child-Pugh B patients. So what I would say is that for true Child-Pugh B patients where I really think that their liver is compromised, often I'll use single agent TKI, most often sorafenib, since it's probably the best studied in Child-Pugh B. There is data for, again, nivolumab as a single agent in Child-Pugh B. I think that's also a reasonable and very well tolerated option. But more and more for Child-Pugh B, technically just because of the numbers, but where I really think the liver itself is okay. They just happen to have low albumin because they're not eating much because they have a lot of cancer. I still will treat those patients with bevacizumab.
Yeah, that's exactly right. When we take a look at sort of evidence base for Child-Pugh B patients, the best data that we have, as you pointed out, sorafenib. So there's a real world registry study, the Gideon cohort, that really showed safety of sorafenib in Child-Pugh B patients. And then, the Checkmate 040 study showed safety of nivolumab in patients with Child-Pugh B patients. So like the evidence base, those are the two agents that have the strongest safety data for patients with Child-Pugh B. And I think those are the two agents that we probably reach to most commonly in Child-Pugh B patients. Although, as you mentioned, devil's in the details of why is somebody a Child-Pugh B? How do they get there? What do they look like? And so I think that there are patients that even if you don't have as strong of an evidence base, we still may consider this in one-off cases in terms of using some of these other agents. I just have a couple other iterations of this in terms of small variations on this case. We've talked about, relative contraindications to beva, but of course there's also the atezo part of this. And immune checkpoint inhibitors are amazing, but, we always think about sort of what if somebody has autoimmune conditions or a liver transplantation, and are you eligible to receive an immune checkpoint inhibitor? So when we think of autoimmune conditions, I think one of the ones that can happen is, let's say, rheumatoid arthritis, well-controlled rheumatoid arthritis. So let's say John had that. Would you consider atezo-bev, or are you like somebody who's like any autoimmune disease, I'm not reaching for it?
I think we're too squeamish with this. I think patients with non-active autoimmune disease, it's totally fine to consider therapy. Where I get a little nervous are patients with truly active autoimmune disease who are on systemic immunosuppression, where, I think I'd be a little bit more nervous. So, rheumatoid arthritis controlled with, just NSAIDs, I would probably go ahead and give the atezo-bev. Rheumatoid arthritis on multiple DMARDs, I probably wouldn't.
Yeah, no, I think once again, probably severity of this. In this case, well-controlled rheumatoid arthritis, I think it'd be a shame to deprive him of the proven benefits of immune checkpoint inhibitor therapy. And I think that you answered this, but I'm just going to point it out specifically. The other thing that happens is not only recurrence after surgical resection, it's much lower after liver transplantation. You're talking about single-digit recurrence rates, but it does happen. So, Mark, have you used immune checkpoint inhibitors after transplant? Do you do this often? What do you do after transplant?
I talk a lot about checkpoint inhibitors after transplant, but I've never done it. I think the risk of rejection is very high. And, as much as possible, we use sort of traditional non-checkpoint inhibitor therapy. So sorafenib, lenvatinib in first line, and then a TKI in second line.
Yeah, I think that's exactly right. So when you take a look at the data, we know from small studies for patients who have any cancer after liver transplantation, not just recurrent HCC, but you may find a patient who has melanoma or some other cancers. The use of immune checkpoint inhibitors after liver transplantation has been shown to be associated with high rates of graft loss. So your graft loss rates are well over 50%, as well as a notable risk of mortality. And I think the summary of this is about 25% of patients die because of the rejection with the use of immune checkpoint inhibitors. So while all of us sometimes get tempted because the outcomes are so good with immune checkpoint inhibitors. I think it's really a high risk endeavor. And, we haven't done it in our center. We were tempted once after we had a patient who failed multiple TKIs, but never did it. And honestly, I think if you're going to do this, it really requires in-depth discussions with a patient about the risks of rejection, if not death, with that therapy. With that, I'm going to hand it over to you to talk through the second case that we have saved up here for the case discussions.
Thank you so much. And so this case hopefully will wrap up a lot of the themes we talked about. We have actually a different patient. We have a 75-year-old male, again, has Hep C, and it looks like pretty reasonable organ function here, and has this new T2 hyperintense mass in segment 8 with marked arterial enhancement with washout at portal venous phase. The AFP is 12, which is just slightly above normal. You can see the scan here with the clear lesion shown. And the patient, again, has early stage HCC, looks like a candidate for resection. So the patient undergoes resection of the mass. Again, one of the major takeaways of the session is don't miss a chance for cure. So a resectable patient should get a resection. This comes out. It's a 7.5 centimeter lesion, and the lesion shows some necrosis. And so maybe just quickly, just summarize here for everybody. Do we have any adjuvant therapy that we can offer this patient? Amit, do you want to answer that?
Yeah, Mark, I think the TKIs right now, unfortunately, did not show any benefit in the adjuvant setting. Once again, exciting, very early data from immune checkpoint inhibitors in a neoadjuvant fashion, but nothing currently available. And so, right now, it's really just close monitoring. This patient would be high risk of recurrence, but hopefully these studies will come out soon and we'll have something in the near future. But I would say nothing right now.
I agree. And then just breezing through this case, unfortunately, he develops recurrence, which is very common, especially for lesions this big. He's got 3 lesions, all confined to the liver. So we would call this patient Barcelona stage B at this point because all the disease is in the liver. And the standard of care in this setting, at least right now, would be TACE therapy alone. And I believe that's what he received. He received a couple of TACE therapies, but unfortunately, he now has developed 4 months later some extrahepatic disease. And so the question is, what would you offer next? This is Child-Pugh A patient, now advanced stage with extrahepatic disease burden, no unusual contraindications. So Amit, what would you offer this patient?
Yeah, I think, Mark, you said it best. You have to really, look for a reason not to offer atezo-bev, and this patient has no reason not to offer atezo-bev. Mm-hmm. So I think he would be an excellent candidate for atezo-bev based on the data we have.
I totally agree. And sure enough, he receives atezo-bev. He has an outstanding response, but unfortunately develops an immune-related adverse event, in this case, pneumonitis. He has some shortness of breath and cough. And, just a review of how we manage AEs, this is a grade 3 immune-related adverse event. We would permanently discontinue, probably in this case, the atezo. This patient went on a long steroid taper starting at prednisone 60, tapered over about 8 weeks, if I remember. This is a patient from my clinic. And the question is, what would you offer next? Again, we don't have great data for anything after bev-atezo, but the most common answer would be a TKI of some sort. In this case, we offered the patient lenvatinib, and this patient is still alive today in my clinic on lenvatinib therapy. So thanks all for this outstanding session. It looks like there are a number of questions in the chat box. So I want to turn it over to Bridget, who's going to lead our Q&A here.
Thank you. Yes, we have a patient with HCC who is Child-Pugh A and had 1 dose of atezo. The patient hadn't started bev yet because they'd had a recent port placement. Started out with an AST of 110, an ALT of 47, a bilia of 0.7 prior to the first dose. And then prior to the second dose, had a bilia increase to 2.7, AST to 265, and an ALT of 127. So she was wondering if we could discuss the likelihood of atezo causing this, or what are the other possible differentials that we would need to consider?
That's a good question. I can answer this one initially. I think when I see immune-related hepatitis, usually the predominant presentation is AST, ALT being quite elevated. And then normally the bilirubin is something that truly lags. So it can be like a long time before you see bilirubin elevations. In this case, what sort of strikes me is that the bilirubin's more elevated, the ACLT not tremendously elevated. So this doesn't look like our standard presentation of immune-related hepatitis. It's also very early in the treatment course, which makes this less likely. I think we haven't been given all the information, like what's the tumor burden in the liver, but I would have tumor progression higher on my list here than the hepatitis from the info that has been given. Amit, what do you think?
Yeah, Mark, I agree. I mean, so typically we think of like a hepatocellular injury pattern when you're thinking of immune-related hepatitis. And so I would expect, particularly for that bilirubin to bump that quickly, the AST and ALT to be much higher, sort of, closer to like, when we've seen the Billy bump that quickly, it's the AST and ALT are like 800, if not 1,000 type levels. And so it's not outside the realm of possibility. I agree with you, Mark. The first thing that I thought about is, did this patient have like infiltrative disease? Did you have more marked progression? And this is essentially now, unfortunately, the patient having progression and signs of liver dysfunction. That's really the other thing that is high on the differential here for the Billy going up, is the patient unfortunately has liver dysfunction from liver replacement. And so that would be one thing that I would be concerned about. The other things that you'd have to just worry about are, does the patient have another herbal they took over the counter, or, a drug-induced liver injury? We always make sure that we're doing a careful history and physical. So just to make sure we're ruling out other causes. So, it's always hard to go through these and piece all the things, but those are the three things that I would put on there. Is I'd say liver dysfunction from liver replacement, potential drug-induced liver injury if the history is consistent. I mean, of course, timing, given the fact that they did receive a dose of atezo, you can't say it's not possible. In this case, given the atypical presentation, I wouldn't assume it. This is somebody where I'd consider a biopsy if there's any question before treating with steroids.
Thanks. I think that's such a great point, because we always want to blame the drugs, and we see there is a time perspective, but I think it's a really good discussion about trying to expand the differential to look at, many other things that might be a possibility. With that, I'm going to switch gears a little bit to talk about some of the screening questions. Question about how aggressive should screening be with a diagnosis of a fatty liver?
Yeah, so, we talked about non-alcoholic fatty liver disease really being, the most common liver disease now in the U.S. and a common cause of cirrhosis. When we take a look at the risk of HCC in patients with fatty liver disease, this really is largely restricted to those patients who have cirrhosis. And so when you think of sort of following and managing a patient with fatty liver disease, the first thing that you have to do is stage the degree of liver damage or the degree of fibrosis. If somebody is non-cirrhotic, they do not need to have HCC screening performed. If somebody has cirrhosis or F4 fibrosis in the setting of fatty liver, they once again then have that annual risk of developing HCC somewhere between 1 and 3% per year, and thereby warrant HCC screening using an ultrasound and AFP every 6 months.
Thank you. Another question about surveillance is, what is recommended surveillance after a patient is treated for hepatitis C?
Yeah, so similar concept here in the sense of the first step in the process is to stage the degree of fibrosis. Much like fatty liver, that risk of HCC is restricted if somebody has cirrhosis. And so if somebody is cured of their hepatitis C and does not have cirrhosis, they do not need HCC screening. But if somebody has cirrhosis, then they should undergo indefinite HCC screening every 6 months using ultrasound and AFP. So even if you see improvement in the liver function, even if you see improvement in platelet count, that risk of HCC is persistent. And so that patient, if they had cirrhosis at the time of cure, should continue to go HCC screening every 6 months. The other sort of concept that I would say here is that even if you cure a patient for hepatitis C, if they have obesity or they have diabetes or they have alcohol use, they have another risk factor for continued liver progression. Even if that patient doesn't have cirrhosis at the time of hepatitis C treatment, they should continue to be monitored for liver progression. And if they develop cirrhosis, once again, then be started on a screening protocol.
Great, thank you. And our last question is, does a liver cyst put a person at risk for liver cancer?
I think, once again, if you're talking about a simple liver cyst, so not something that is malignant in itself, a simple liver cyst does not increase the risk of liver cancer. It does not change anything. So I have to say, seeing a liver cyst is like honestly the most rewarding thing in my clinical practice because I get to tell that patient, you not only don't have cancer, but you don't need to keep following this thing. This is something that is I call it a beauty mark on their liver. It makes them unique. And I tell them they should just keep it in mind and don't let anyone stress them out by having a liver cyst. One of my favorite nice points in the day between sort of sometimes depressing cancer cases.
Well, thank you. I think that's a great way to wrap up. I love your model of calling it a beauty mark. I think that's probably really helpful for patients because patients worry about these things. We find all these incidental findings on all the testing that we do. And so it's helpful to have a context to say, we're worried about hepatitis C, but we're not worried about liver cysts. So I think that's a really good way to kind of wrap up our day. I think it's been an exceptional program. I'm really happy to have shared this time period with, the faculty as well as all of you.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.